Okay, good morning, good afternoon, and thank you for joining our session. I am Rebecca Ross. I'm a Senior Technical Advisor on HP Plus, and today I'm going to give a quick introduction to our family planning technical efficiency tool. Seems like we still have a few people joining, but that's okay. To get started, as kind of a warm-up, we have a poll, and in the last session, I was unable to launch it. So if that happens again, it is on the screen with the questions, and you can put your answer in the chat. We are asking for the definition of technical efficiency. Great. Thank you, Sunita and Tom. Welcome, Tom. The correct answer is A, C, or D. B defines allocative efficiency. So if you said any of the other three, you were correct. Technical efficiency is the effectiveness with which a given set of inputs is used to produce an output. Improving technical efficiency has emerged as a priority issue given funding constraints and declining external funding for family planning. We have tools like Optima and List that are used to improve allocative efficiency, but there aren't technical efficiency models for policymakers. Most existing models, like data envelopment analysis, measure efficiency in service delivery, and don't provide mechanisms to identify root causes or potential policy solutions to inefficiencies. Existing FP efficiency studies focus on facility or community level integration of family planning with other health programs and management of health workforce inputs through means like task shifting and task sharing. While these initiatives can promote efficient use of resources available for family planning service delivery in the health system, they are a bit narrow in their focus. In response to challenges in measuring and addressing technical efficiency of family planning, HP Plus developed an analytic tool to assess the technical efficiency of family planning programs across levels of the health system. The tool was developed based on literature review of technical efficiency assessments, consultations with family planning experts, and a review of financial and family planning data availability. The tool has 3 modules to diagnose, identify, and systematically pursue solutions for inefficiencies in the program. And I will give a brief overview of each module. First, we complete an inefficiency diagnostic. We compute input-output ratios to assess how different family planning program components are performing relative to the resources invested or used in each component. For example, on task shifting, the tool assesses if task shifting as currently implemented results in more people receiving family planning services from lower level cadre. For each component, 1 input and 1 output indicator is used. Indicators are selected based on data availability and consultation with in-country stakeholders. And here we're showing the 26 core family planning components across service delivery, demand creation, and enabling environment that are included in the tool. So for each one of these like colored boxes, that's considered a component. For each one, we identify an input and an output indicator. For each component, there are 1 or more representative input and output indicators proposed in the tool. And using in-country data from survey and program data or stakeholder discussion, indicators and estimates are determined and a ratio is automatically calculated. Then we assign an interpretation ranging from likely to be inefficient to no signs of inefficiency. The interpretation will depend on the specific input or output selected. For many components, the optimal ratio is 1, so any deviation from 1 indicates a possible inefficiency. For many, the larger the ratio, the greater the inefficiency. Here we show an example from the Malawi implementation. This is the input and output indicator that were selected to assess postpartum family planning services, with the ratio and interpretation towards the bottom of the slide. It's considered inefficient because there are more service delivery points providing postpartum family planning services than there are clients accessing them. Those components identified through the diagnostic assessment as potentially inefficient proceed to the root cause analysis stage. For each potential inefficiency, root causes are selected from a list of preloaded options that were informed by the literature review. Additional root causes can be entered manually in response to the unique country context. These are identified and discussed during in-country consultation with family planning stakeholders or technical working groups. The example here shows the root causes that were identified in the Malawi postpartum example from the previous slide. Finally, with the subset of inefficient components and their root causes, we proceed to identification and evaluation of solutions. This is the third module. This module does not feature preloaded solutions. Instead, the solutions are identified during in-country application of the tool and are vetted with stakeholders. The proposed solutions are then scored based on 4 criteria. The first, whether the family planning program has control over implementation of the solution. Second, consideration of how long it will take to implement the solution. Third, associated costs, and fourth, perceived effectiveness of the solution. Those solutions that receive the highest score will be prioritized for implementation in country. The higher the solution score, the more feasible the solution is considered. Answers for the 4 assessment questions were collected from in-country stakeholders, and in our initial implementations of the tool, as a final step, identified solutions were then categorized into 4 priority areas, which are shown here for both Kenya and Malawi implementations. The results of the implementation in Malawi and Kenya, including details of each module and phase of analysis, are available in briefs on our website. I will put the link in the chat after the presentation. Here we list some of the overall strengths and weaknesses of the tool. In particular, with the tool, we're able to assess technical efficiency across components and levels. It's customizable using country-specific inputs and outputs, and maybe most importantly, it's engaging and ultimately highlights a path for improving efficiency. But there are some limitations. The ratio scores don't account for confounders or other factors affecting the program. Some ratios require nuanced interpretation. And importantly, in our implementation of the tool in both Kenya and Malawi, we use national level data or averages across subnational units. So the diagnostic assessment is reflective at the national level and may not be relevant at the subnational level, but the tool can be implemented at subnational levels. And finally, completing the diagnostic assessment requires significant data inputs, because as a reminder, you're selecting both input and output indicators across the 26 components. So that's 52 indicators, which may not be up to date or readily available. I'll add, sorry, before moving on, we are finalizing the tool and a user guide, which will also be available through the same link on the website in the next few weeks. So the user guide details step-by-step how to go through the tool and suggestions and recommendations based on our implementations in Kenya and Malawi, and both will be downloadable from our HP Plus website. I would like to open it up now for any questions. If you have a question, please feel free to just unmute and ask. And while we're doing that, I'm going to switch the view. So instead of seeing the slides, I'm going to project the Excel file with the tool itself so that we can just briefly walk through that.
I see Tom has joined the meeting. Oh yeah, let's look at the tool.
So here's just the cover page, but to show the 3, I think most interesting is looking at the 3 different modules. In the diagnostic assessment, which is the first tab after the cover. Here you'll see on the far left is the space for input, indicator selection, value, source, and year, and output. The all input and output indicators you can see, or maybe it's too small, are drop-down menus. So you can pick the one that is that you have most recent data for, or the task group or local in-country stakeholders decide is best, and doing the same with the output. And I would say the importance of putting the source and year is trying to be sure that you're aligning the comparison, particularly in year, so that we aim to have most recent or most updated inputs, and you want to be sure that the input and output are of the same year. Moving over here, this in column K is where the ratio would be automatically generated, and the interpretation ratio is then assigned. Any that are inefficient then are populated into the root cause analysis tab. And here again, we're showing you can either choose a root cause from a drop-down menu, or you can insert other and insert something else. We provide up to 5 spaces for root causes. Again, you can add more. And then from here, we'll go to the solutions tab. And again, we have 5 spaces for solutions to be identified, and then the assessment across for each solution identified. And we used closed-ended questions in both Malawi and Kenya to try to get estimates for these. They are not exact numbers, so you can see that here. It's whether or not there's control of the implementation by the FP program, yes or no, how long it will take, less than 6 months, 6 months to 1 year, a year to 2 years, or over 2 years. A estimated cost, again, this is just an estimate, not a costing activity, so this is approximately how much the solution might cost, and effectiveness. And then a solution score is generated, and solutions are prioritized based on their feasibility or the solution score.
Thank you, Rebecca. So how do you identify these root causes? Like, it's more like you're saying provider bias. So it means over dependence on 1 or 2 methods. Like what is happening? How do you know that's a provider bias? And what is efficiency solution there?
For all of them, we gathered stakeholders from different implementing partners, DOH, we had county reproductive health coordinators and others join a task force, and we met with them to go through them. So we would talk about what we met to discuss which input, which output indicators should be selected. We meet again for continuation in the afternoon to discuss the ratio and the proposed interpretation that can be modified, and then we meet to go through the different ratios. Like what the root causes are. So in Malawi, that was full group discussion. It was all virtual. We did it, throughout COVID. And so we had the whole task force on calls, the slides up of what the root causes are, and discussion and back and forth between different participants about what they thought was the explanation of that inefficiency. With the Kenya implementation, we had a multiple day workshop. So people were brought together, and they had people sitting in groups, and they did it as groups. And so then the groups came up with that sort of process and then discussed them across the different groups. So that's how they were narrowing it down, identifying which were the relevant root causes, and then similarly identifying solutions and agreeing on kind of that solution score.
Thank you. Ina.
Yeah, no, thank you, Rebecca. If you're able to just show us the tool once again. I have a question about the data sources. It's probably quibbling, but we all know the state of data, and it isn't always possible to sort of have them align in terms of years, or even in terms of sources and the reliability of sources. So, Sunita knows I've mucked around in tools in the past, and sort of, I used to work with Avenir Health at one point, and one of them used to say garbage in, garbage out. It depends on your sources, really. Where are you getting these numbers from? So my question is a simple one. Is there any way to, if you don't have the same years, for instance, does that affect the reliability of this tool? How does that work? And apologies if this is too back end, just curious.
It is an important issue, I would say. And I agree with your Avenir colleagues of garbage in, garbage out. So, this is dependent on what information we feed in. So that in both implementations was a challenge of finding aligned years or close enough if we were using two different data sources, and being sure that the definition of the indicator, so what is actually being measured, even if they are different sources, is in alignment between input and output. We do have, I think, across, the answer would be in the brief, but I think for the most part, we consistently aligned data years. So we were comparing, it wasn't always the most recent. We sometimes had to forego like the 2019 or 2020 estimate because we didn't have the aligned input or output, whichever direction we were working in. So we would end up with a 2016 or 2015 even indicator. But for the most part, we were particular about aligning at least data year and being sure that what's being compared is, in alignment. That is a challenge. That is why we say that the data requirements of this tool is one of the challenges, because it is a time-consuming, a difficult effort to try to make sure you have all of that data and that it's all, reliable. We presented in both instances. We had multiple consultations in country with the task force or team working on this implementation. And so we had agreement among stakeholders about the data source and the estimate and what was being compared before moving on to the next stages. We went through, I think in Malawi, it was multiple diagnostic assessment meetings to get to that point where, there was a disagreement or we lacked consensus in terms of one of the components, and we would go back and try to find some different data sources that were suggested. And we ultimately ended up adjusting some of the indicators to be sure that it was, we had the right data and it was reflective of the component. And I think at this point,
Sorry, we're being summoned.
Comments. Dina is.
That's what I was just about to say. I'm so sorry that we ran over. Thank you for joining.